Right, so hi everyone. Happy Friday to everyone from all over the world. On behalf of the Asian Association for Emergency Medical Services and the SingHealth Duke Global Health Institution, we are very excited to have all of you here for our very first Asian webinar on our EMS experience with COVID. Okay, I do apologize that you have, some of you all who came early had to hear our discussions. So this is our first time having such a big crowd on a webinar. Hence, we had to go through some technical housekeeping matters before the actual session start. So this is not a practice. Our session has officially started. Okay, so a few housekeeping matters. All mics will be muted unless you are the speaker. Okay. Second, in the interest of time, we will let all the speakers present first. If you have any questions, please type in this Q&A box that you will see on your screen. For those of you who are familiar to Zoom, this Q&A box is different from the chat box. So the chat box is for us to chat to each other, while the Q&A box is specifically for questions, which will be directed at both the speakers and the panelists. So when you type the questions there, only we can see them, and we will try to address them at the end of the session. Okay, if we are unable to address all the questions, we will attempt to mail out the answers later on. Okay, the other thing is, in the interest of time, we have to keep to a strict time limit. Okay, so the bell will ring when just 1 minute before the speaker is due to finish, and the bell will sound like this. Okay, so for speakers who hear this, it means you have 1 minute left, so please try to wrap up. And for the Q&A session, 5 minutes before the session ends, the bell will ring. Okay, so it means we'll have to wrap up our session. Right, so to start off, we will invite Professor Matthew Ma, Chairman of the AAEMS, to give his welcoming speech. Prof. Ma, please.
You hear me?
Yes, we can hear you, Prof.
Okay. Good afternoon, our friends in Asia and across the world who are currently joining us in the webinar. Right now, we have over 250 people. On behalf of the Asian Association of EMS, I'm privileged and honored to open this webinar entitled Lessons Learned from the Hill, Asian Emergency Medical Services Response to COVID-19. Hosted by the Asian Association of EMS and the SingHealth Duke-NUS Global Health Institute, the webinar will highlight stories from leading experts in the fields of EMS and emergency medicine. We hope this webinar will provide insights on different challenges faced and strategies employed in containing the COVID-19 outbreak in the range of EMS settings in Asia, as well as provide a platform for discussion of best practices. Asian Association of EMS was established in 2010, and we aim to be the Asian hub of EMS expertise. Over the last 10 years, we have grown into an association with members from over 20 countries and regions. Today was supposed to be the opening day for our biannual conference, EMS Asia, to be held in Tokyo. In March, we decided to postpone the conference to fall next year, as all our members are leading response efforts in their respective communities. It's therefore heartening that we can get together this very same day, June the 5th, several months into the pandemic, to report and to share our life stories during this unprecedented global calamity that would definitely change our ways of life in the days to come. Today's webinar is indeed a very special way to celebrate the association's 10th anniversary, and it truly reflects our idea of a localized EMS, where we achieve EMS excellence collectively through incorporating global wisdom and proposing local solutions. Finally, I would like to thank all our speakers, moderators, and panelists, our teams from AAEMS, and SingHealth Duke-NUS Global Health Institute, and all of you in the audience for making this first webinar a reality. I hope you will enjoy today's webinar and bring back something that would definitely benefit your communities. Thank you, and enjoy the talks.
Thank you, Professor Ma. Okay, right. So now we'll have our first presentation. We'll have Professor Ma to present on a concerted community effort. How did Taiwan do it? So besides the many hats he wears, he's also the Professor of Emergency Medicine, National Taiwan University. Professor Ma, please, over to you.
Thank you, Gayathri. So again, good afternoon, friends everywhere across the globe on the internet. I would like to spend a few minutes to share with you the experience of Taiwan in combating coronavirus COVID-19 from both a community perspective and also from an EMS perspective. We know Taiwan is very close to China, with over 850 people living, working in China. It was predicted to be the place with the highest risk or impact from the new COVID-19 disease. But up until today, we have only 443 confirmed cases in Taiwan. That was far behind most of the countries in the world, in the region. And how did Taiwan contain the spread of the virus with such a high risk? During the pandemics, all the schools remains open, the economies remains open, and there's no whatever lockdown in the communities, and even the ball game continues. I think the community containment in Taiwan benefit from it's very well prepared and early action, because we suffer from the calamity of SARS epidemic in 2003. So after that, the pandemic response program was overhauled and institution policy renewed and a lot of preparations being done. And the system is always on vigilance of new emerging infections elsewhere in the world. Interestingly, this is December 31st on 2019. The deputy director of Taiwan CDC was in the middle of the night. He was browsing the Taiwanese version of Reddit, it's a chat room, and he ran into this posting describing a cluster of atypical pneumonia possibly caused by coronavirus in Wuhan, and with some of the local information. And that raised the concerns and the awareness of the Taiwan CDC. So right on the same day, on December 31st, Taiwan CDC started border control and started this onboard quarantine for flights from Wuhan. So that's the beginning of our reaction to the new COVID-19 pandemic. So it was very early. From these two slides, you see the events and reactions between Taiwan, China, nearby Asian countries, and other countries in Italy and US. Actually, they are very similar. We were all doing very similar things. Only, I think we started earlier with mask rationing and also traffic control, a little earlier than the rest of the countries. And after that, we started a series of quarantine measures for inbound travelers, originating from border control all the way to home quarantine and isolation. During the SARS epidemic, we also suffered from the shortage of masks. So we realized actually facial masks, surgical masks, these supplies are of strategic importance. So right into the pandemic, as early as January 23rd, there was a ban to export any mask elsewhere outside the country. And there was a country team to gear up the production of masks from 1.8 million per day up until now we have 25 million per day. And we also started the name-based mask rationing for the population. A second key point is an early institution of centralized command center. This central epidemic command center was started January 20th. So they can coordinate all intergovernment policies and actions. This was led by the Health Minister Chen, who had been doing this press conference since January 20th, present facts, explain reasons, clarify rumors, and answer questions every single day. So in the later half of the epidemic, he became one of the most popular person in Taiwan, receiving approval rating over 95%. It's very amazing. In response to the call for a mass survey, he became a professor in Epidemiology 101, explained in plain language to the general public why it's not a good idea to do a mass screening when we have a very low prevalence in the community, which would lead to unnecessary false positive rates. In addition to this conveying of fact, information, and science, they also tried to convey a sense of empathy and humor during these daily communication. When they heard about one of the boys was bullied in the school for wearing a pink mask, in the same day in the afternoon, all the commanders wore pink masks in support of the boy. And a lot of the actions and directions were translated into a cartoon given by our mascot commander. This is the Shiba Uno, teaching people how to keep social distance. And this is a very humorous, amusing ad showing the rear end of our prime minister, the premier. And he says, we only have one pair of buttocks, stop hoarding tissue paper. So this actually stopped the community hoarding of tissue paper in a few days. So a third part is the ability to consolidate our national health insurance infrastructure together with IT technology and big data analytics. So in the early stage of the mask rationing, there are tons of different apps and mask maps showing where you can get facial masks in a nearby national health insurance drugstores. So people register using their national health insurance card and get their rationed mask in the nearby drugstore. In the later stage, you can actually get your mask at the nearby convenience store, 7-Eleven or Family Marts. To protect our health systems, the data from national health insurance is linked with border control. So on February 18th, all hospital, clinics, and pharmacies could scan the national health insurance card and access patients' international travel history so they can arrange necessary TOCC checkups. And from March, this also very important information is made available to all fire department dispatch centers. Another part of the IT work is the development of the digital fence system utilizing mobile signals. Your location is constantly monitored every 10 minutes and will be reported if you violate the regulation. The system now has the capacity of monitoring up to 100,000 persons in the same time, and became one of the skeleton, one of the backbone of a very comprehensive quarantine system, starting from the border all the way to home isolation and quarantine. The very famous Diamond Princess cruise also docked in Taiwan for one night. Thousands of people went on board. In order to conduct the contact tracing, technology with big sensor data and contact were used so we can route the passenger routes and also to notify potential contacts for their potential contact with these people. About 1.5 months ago, there was a Navy supply ship Panshi cluster. And after that, 700 sailors went on board. In order to trace the whereabouts of these sailors, again, the digital contact tracing technology was applied. So I would say early reaction and preparation, very good and transparent communication within the general public and the command center, and finally the widely use of technology and IT and national health infrastructures helped us to combat the virus from a community perspective. Now I'd like to switch gear to describe the role and the goals of EMS during the pandemic. And I will use the response in Taipei. Example, Taipei is the largest city with 3 million population. And during the pandemic, among the 443 confirmed cases in Taiwan, 91, about 20%, were sent to hospital by Taipei 119, our ambulance system. During the pandemic, there's a 6.5% decrease in the demand of our call volume, the EMS call volume. And the essential priorities for the EMS in Taiwan are threefold: to protect EMS providers and to provide optimal best patient care while we want to maintain EMS capacity. In order to do that, there's a lot of updating and promulgation of procedure, practice, and stockpile PPEs. And the EMS response starts with dispatch screening. And the goal is to facilitate tiered PPE provision. Those considered highest level were the calls dispatched from health department or the Taiwan CDC. And these will be dispatched with designated AOS services wearing bunny suits. And those categorized with COVID alert are those with positive TOCC responses, and they will be sent with standard COVID PPE with N95, face shields, isolation gowns, and gloves. And the other of the response will be considered general cases. They will be sent with surgical masks, goggles, and gloves. This is the data showing the volume of COVID-19 related transports, including suspected cases and confirmed cases. You can see starting from early January all the way until the end of May and June, we have higher pressure against the system from early March to middle of April. Most of these are visitors coming back from North America and Europe. These curves represent cases with standard COVID-19 PPE and those with full gear bunny suits. The blue represent standard COVID, representing those people with positive TOCC, and the red curve indicating numbers necessitate the bunny suit. And you can recognize the numbers are relatively small because the total number of clusters or outbreaks in Taiwanese communities are relatively small compared to some of our Asian neighbors. We also prepare a dashboard to monitor the provision of PPE supplies in the system. You can see for most of the supplies, we are in safe place. Usually we have 3 months of supplies in stock. This is a very interesting idea proposed by Dr. Ho. It's called Taipei Azalea. It's a pre-packed SGA linked with a filter and wrapped by a CPR training mask. So the SGA could be quickly placed during a COVID-19 pandemic and a cardiac arrest patient. And we submitted to the journal. It's without saying that PPE donning and doffing, as well as decontamination of the vehicles, are very, very important. In addition to hands-on practice, numerous hands-on practice, we also produce many of the e-training material online to be made available by our providers so they can review on their personal time. For those people who are aware of the EMS system in Taipei and Taiwan, they probably are aware of the generous community support in our EMS. For example, all our ambulances are actually donated by the temples. So very similarly, during the outbreaks, over 80% of all the PPEs coming from donations, either private donation directly or money donation. So all these efforts would not be possible without the generous support by the leadership and the infrastructure. So with the proximity of Taiwan being so close to China with frequent interactions, we remain very small numbers of COVID-19. I think the successful containment of the virus in the island was due to fast response, early vigilance, a very transparent and trust environment between the whole community, very frequent and effective communication across all levels of life, and also a benefit from the newer technology and big data analytics. Thank you very much. So that's my description on the Taiwan response. Thank you.
Thank you very much, Professor Ma. Next, thank you. Okay, so once again, please keep your questions for later. Type in the Q&A box. Next, we'll have Professor Herbosa from the Philippines to talk about the impact of enhanced community quarantine in the Philippines. He's also the Professor of Emergency Medicine, College of Medicine, as well as the Medical Director, Philippine Society of EMTs. Professor Herbosa, please. Thank you. Over to you.
Thank you, Gayathri, and good afternoon, everyone, to all my colleagues in emergency medicine and the field of EMS. I'm so happy that we could still join each other virtually despite the pandemic. So I'm here to share the experience of the Philippine Islands in terms of what we've done in terms of our non-pharmaceutical measures in trying to stop the progression of our pandemic. COVID-19 has been a great impact to the health system. Our health system is very fragile. It's not as strong as that of Taiwan. And we had to impose community quarantine. We started with general community quarantine, went up to enhanced community quarantine, and some areas had extreme enhanced community quarantine or really severe lockdowns. This is the national plan of the National Task Force for COVID-19. I'm actually one of the special advisors to the National Action Plan. And it talks about a T3 management system, which is basically hunched on testing, tracing, and treating. So we go through all the aspects of prevention, all the pharmaceutical measures, keeping 1 meter distance, the wearing of face masks, which initially WHO did not want us to implement, but we decided to actually implement universal masking for the public, as those were the ones done by Taiwan and our colleagues in South Korea. We did PCR testing. We had an initial capacity that was low, about 3 labs in the beginning of January. We have now capacitated to 52 PCR molecular laboratories. And then we've done our active contact tracing. Not very good in all, not as good as that of Taiwan, but we've done our own contact tracing in some cities with using data and geospatial analysis. And of course, we built up our quarantine facilities. We used our World Trade Center, our sports facilities, and we improved our capacity of the health system because at the end of February, our private hospital system was already overloaded. And then we started to learn from our colleagues from the other countries on how to treat these people with COVID-19. This is the epidemic curve of confirmed cases in the Philippines. At present, we have about 20,000 confirmed cases of COVID-19 in the Philippines. And we are now in the deceleration phase of our epidemic curve. And we've now released our community quarantine to what we call general community quarantine until June 15. We will be the country with the longest community quarantine, longer than that of Wuhan in China. This is our case fatality rate. As you can see, we are now seeing the drop in our case fatality rate. It's still actually high because it's somewhere in the figure of 5, 6, or 5 case fatality rate, which is just below the world level. This is a mapping of the geospatial cases. The darker the orange color is the more number of cases. As you can see, Manila, Cebu, and Davao are the peak cases that happened, but the rest of the country have 0 or little cases. We are now going into a new phase wherein we attack it from a barangay or the smallest township level. And these are still the picture of Metro Manila as the cases or barangays that still have some level of cases. We currently applied the CBRN approach of zoning to be able to release ourselves from enhanced community quarantine to now more specific zoning of places, depending on the number of cases in each barangay, maybe a street, a block, maybe even a building. So that becomes more granular and more specific in our approach to contain the transmission of this disease. So over on the right side, you see how we've gone very, very slowly because our health capacity is not as good as that of the other countries. So this is what we plan to do. We expect to be out of community quarantine by July 1. Over on the left, you'll see our comparison of our case fatality rate with the world. The red one is the world, and the Philippines is just below, a little bit below the world average. But you can see our colleagues of other countries, South Korea, and other countries with very low case fatality rates. Over on the right is our spot map diagram of live cases in metropolitan Manila. This is a map of the National Capital Region. Well, the EMS was affected because we had to repurpose our personnel from the EMS. You can see here being used in some of our public health measures. Our EMS staff have been used to do the temperature checks in entry to specific places or public places. This is our biggest private ambulance service, Lifeline. And they also implemented risk assessment of their personnel, those that are in the base and those that are exposed in ambulance runs, and provided specific measures for all of that. Of course, it's very important that we follow all the measures, the public health measures, to actually identify and contain and prevent transmission of the COVID-19. The second largest EMS group in the Philippines is really the Philippine Red Cross. After the government, there's the Philippine Red Cross. What they capacitated is their ambulances with negative pressure. So this is a news article of the application of the delivery of negative pressure ambulances for COVID-19 positive patients. We also had some incidents. We had, I think, a foreigner that was going to be transported via Japan, but the airplane crashed. This was an air ambulance run, and we have the picture of our emergency doctor who was accompanying that particular patient. But sadly, they crashed immediately after takeoff. So our friends in the field of emergency medicine, the Philippine College of Emergency Medicine, and our colleagues in the Philippine Society of EMT have all been the frontliners in this particular battle. Of course, our EMS field has been in the Philippines for more than 20 years. We've transported some of them to different parts of the world, also facing COVID-19. This is the president of our Dr. Bokar. She visited with her team to the Operations Center of the National Task Force, where they presented a coordinating system because everything changed with community quarantine. Hospitals were reassigned. We had 3 specific hospitals that were COVID hospitals, and several of the other hospitals were too busy or too overloaded, so that we need to direct patients, and they developed a central coordinating system together with the National Task Force, which was actually presented so that the command center can help the transport of patients. In the beginning, we had horror stories of patients traveling from one hospital to another, getting refused, and eventually going outside Metro Manila to become admitted. So these are just some of the protocols that were presented. We had actually scheduled the National EMS Week. Every year, around May, in the latter part of May, we actually have an EMS competition, an EMS scientific conference that we hold annually. But this year, we had to postpone it because of the stay-home community quarantine policy. But our colleagues in the society decided to come up instead with a webinar similar to what we've done. And there were 3 speakers on 3 different days. This was the first one on May 20. And there was a second one on May 21, and the third one on May 22 with our friend from Indonesia, Ali Haedar, giving his talk. They also decided to just have, instead of an EMS competition, a photo competition. And they submitted, I think this is the winning photo, if I'm not mistaken, but these are some of the photos of the people in action to actually show the, this was also a placer. It's a panganib or fear in English, is the picture of our colleagues in emergency medicine and EMS. We also hold our annual conference right smack in the pandemic time, April 19. And during this time, we decided again to hold our huge annual meeting of the Philippine College of Emergency Medicine on a virtual mode. So it was actually canceled first. And then a week before this, they said, are you willing to talk about what you're doing in the National Task Force? So I gave a talk. And a pulmonary expert gave a talk, another emergency medicine doctor in Manila Doctors gave a talk, and so on. And we got an instant national virtual conference. We also contributed in the production of ethical guidelines. Apparently the infectious disease people and the ethical experts decided to put COVID-19 guidelines after the horror stories of Italy. We were able to contribute this because they valued our inputs as emergency doctors in terms of the perspective of the ethical issues from the emergency medicine point of view. These are some of the algorithms given to me by some of my EMTs who are working in the Middle East. Of course, in the Philippines, our protocol has been to protect the patient, really being able to give a bag valve mask that is truly fit like an N95. This is our Department of Health and the Department of Interior and Local Government guidelines on the treatment and COVID-19. We call it community quarantine areas or ligtas COVID areas. And incorporated this in Article 6 are the specific guidelines for referral and transport of patients and specimens. So this is where everything was put into. We have what is called an epidemiology surveillance unit that comes out. So my bell has been mentioned. And I'll just go through some of this. This is the most important slide. The EMS people had become more cautious. They developed new protocols. They got scared. They transported positive patients. They sanitized their vehicles after each run. They had colleagues who contracted COVID-19. They had less emergency responses because of the community quarantine. They ran out of PPEs and N95 masks, and they had to stop EMS service because of this. And they had colleagues that had died from EMS service. So this is one of the comments of how they will continue to serve our EMS colleagues even beside the pandemic. And I end with this: coming together is the beginning, keeping together is progress, working together is success. Thank you very much to all our frontliners and all our colleagues at the Asian EMS. Thank you very much.
Thank you very much, Professor Herbosa. Thanks a lot. Okay, right. Next up, we have Professor Lee from the Department of Emergency Medicine, Kyunghee University Hospital, South Korea, to present on how did Korea flatten the curve.
Hi, I'm Dr. Lee. I'm a emergency physician, chairman of the board, Korean Council of EMS physicians. First of all, there are lots of patients suffering from COVID-19 in the world. Large number of people already died. And as you know, many healthcare providers, including emergency physicians, have died. On behalf of KC EMSP, I express the deepest condolence to them. And thank you very much for your hard work at the EMS and Department of Emergency Medicine in the hospital. Today, I'm going to talk under the title of How Did Korea Flatten the Curve, focusing on the response of EMS to COVID-19 in Korea. This is the figure captured on YouTube, officially produced by the Korean government. The cumulative number of COVID-19 confirmed patients reached 10,000 in the late February, and less than 2 weeks later, exactly after 10 days, it reached 7,000 on early March. The graph, which have been a very steep slope since end of February, is slowing a gentle slope. So Korea flattened the curve. Some of you have already read it, the New York Times. And the Korean government and the medical community have engaged in a 3T strategy in responding to the COVID-19 pandemic: test, trace, and treatment. In Korea, only RT-PCR was conducted by the doctor in the hospital, public health screening center, not in EMS. Drive-through screening center have been created to test many people quickly and minimize transmission of infection. Walk-through screening center have also been created to minimize medical staff exposure and to allow rapid disinfection of booths to ensure safe and prompt examination of patients who visit hospital and public health center. Everyone entering Korea from abroad had to do self-monitoring and reporting through mobile app. The same was true of a domestic COVID-19 contact who had to be quarantined for 2 weeks. In the event of COVID-19 patient, CCTV, mobile phone, or credit card use were investigated, and the COVID-19 confirmed patient route was disclosed to the local government website and social media. All of these were using Korea's excellent IT technology. It was in accordance with Korean law and not illegal, but these methods were at the expense of people's freedom, I think. The extensive and rapid testing is not enough. A healthcare system that can provide appropriate treatment for COVID-19 patients is important. In this regard, I think the National Health Insurance and EMS system in Korea have been successful. If a doctor conducts an RT-PCR test for suspected COVID-19 infection, the patient was free of charge. And even if a man with no symptoms and no travel history and no contact with COVID-19 suspected wants to do the RT-PCR test, it costs only about $80. Even treatment costs, including the negative pressure isolation room for COVID-19 confirmed patient, were all free. For patients with asymptomatic or mild symptom of COVID-19, a single room was assigned for each patient in a facility called the Living and Treatment Center. It's not a hospital, but doctors and nurses were deployed. Now, let me tell you about the EM system in Korea. Like Japan and Republic of China, Taiwan, Korea has a fire-based EMS system. All the firefighters are government officers. They follow hierarchy, wear a uniform, and the command system is similar to the military. NFA, National Fire Agency, has one central agency and 18 regional fire headquarters. You can see the EMS division in the NFA central agency. This is a usual firefighter EMS provider before COVID-19. When an ambulance is dispatched, one is for driving, two for patient care. You can see a dental mask and gloves. All the pictures of my presentation is on my use of what was reported in the newspaper and in the media. And this figure shows Organization of Infectious Disease Crisis Response Center, so-called IDCRC for COVID-19. This figure shows the firefighter EMS provider in COVID-19 pandemic, PPE. Yeah. We usually call a 5 pieces set, similar with other countries. Due to the lack of N95 mask, most of them wear KF94 mask. KF94 mask approved by the Korean government and blocked the 94% finders, so we call the KF94 mask. This is a PPE indication for firefighter EMS provided by NFA manual. You can see the unknown mask history and unconscious cardiac arrest. So virtually, in most of ambulance run, they wear PPE. In Korea, NFA has only six negative pressure ambulances before COVID-19 pandemic. So all the ambulances were packed tightly inside with the disposable vinyl before ambulance run. This is a picture of transporting patient to the hospital. You can see the hospital medical staff wearing a PAPR, powered air purifying respirator. So some were given to the emergency department, but mostly to the ICU medical staff. Next, the ambulance you can see and firefighter EMS provider wearing a 5 pieces PPE. After transporting of COVID-19 confirmed patient to the hospital, they return to the fire station and disinfect the ambulance according to the NFA manual. And they ventilated the ambulance for 2 hours after disinfection. Now let me tell you the latest status of COVID-19 in Korea. COVID-19 tests were conducted on nearly 900,000 people, and with more than 11,000 confirmed, and death toll is 271. If you look at 18 region, you can see the number of patients is very different. Daegu metropolitan city, the population is 2.5 million. The confirmed COVID-19 patient is 4 digit. This figure, you can see the more intuitively know the status of Korean COVID-19 confirmed. I think the circle of around Daegu should be much larger. Yeah, more than 11,000 patients have been reported in Korea so far, but they are concentrated in the Daegu area. You may wondering why. Oh my! Please give me more seconds. You may be wondering why. This is the latest official KCDC report. You can see Daegu, surrounding Daegu area, Gyeongsang, Dukdo is more than 70%. And you can see the Shincheonji. On purpose, I wrote a Chinese character. Some of you know about the meaning. New word. It is a cult, pseudo Korean Christ Church. Yeah. So we don't know exactly why, but there was also Shincheonji Church in Wuhan, China. It is known that people from the Wuhan Shincheonji Church visited Daegu Shincheonji Church because of a sisterhood relationship. CDC HQ, Central Disease Countermeasure of HQ, headed by Prime Minister, has issued the crisis pages as following for different stages. It will be easy for you to understand as the patient occurs. When the first COVID-19 patient was confirmed in Korea, the government immediately raised the crisis level from blue to yellow. A week later, they raised the alert level, but after more than 2,000 patients was exploded in Daegu, they raised the highest level of red alarm. At that time, the government hesitated. The medical community insisted that the highest level of red alert should be issued quickly. Man doesn't know the future, but looking back, I think the Korean government's crisis response is just a little late. NFA responses to crisis alert page by CDCHQ. This is a part of manual. And as earlier I said, Daegu is exploding for COVID-19 patient. So NFA mobilization of EMS pulse to Daegu four times, and the national number of ambulance is 1,500. So about 10% ambulance is mobilized to Daegu. You can see this is a mobilization of the first or second, third, fourth. And before red alarm, NFA mobilized the EMS pulse quickly. And this is a disengagement. So it means the slope is less steep. Yes, this is a real photo of mobilization of NFA ambulances to the Daegu. And during the mobilization of 41 days, they transported more than 7,000. By simple calculation, the workload is not heavy, but in the peak day, you can see, in the peak day is just a single day, 909 patients was confirmed. At that time, only only one first and second after the second mobilization. So combined with Daegu ambulances, it was a heavy burden. I think it must have been incredibly difficult, I think. Lastly, I'll briefly talk about SMICU, funded by a Seoul municipal government, interfacility critical care transport with the Seoul National University Hospital, operated by Seoul National University Hospital. In this time, SMICU successfully transported critically ill COVID-19 patient. This photo shows a real photo. This photo shows a SMICU staff wearing a PAPR and negative pressure stature current during transport. And you've never seen in the firefighter EMS provider in Korea. Yes, thank you for your attention. Thank you.
Thank you very much, Dr. Lee. Okay, so once again, we'll take questions at the end. Next, we'll have Dr. Son from Vietnam, who's the head of critical care unit, Deputy Director of Department of Emergency Medicine, Bach Mai Hospital, to present on public health interventions. What did Vietnam do well? Dr. Son, please.
Hello, panelists and friends on internet. And today I'm very happy to show you something, but I am sure that it's not like everything we can see that in Vietnam. So I'm not sure how I can put it in. Is that okay?
Display, yeah, perfect, great.
Okay. So just very brief talk about how we respond in Vietnam during COVID-19. So first I want to talk about the current situation of COVID-19 in Vietnam, and second talk about the brief report on the healthcare system, how they respond and the result of that, and next talking about the EMS system in during COVID-19. So we have the first case in Vietnam in January 23rd. And the number of cases increasing more after from Wuhan, China. And at that time, we think that every case from China, so we block the border with China, and we do quarantine at the airport for the people from travel from China. But later on, that situation changed because we have more cases from Europe. And at one time, we almost like declare that victory, but the second wave from Europe make us more trouble. So that's why we have the state emergency declared in April 1st, and we total lockdown for 2 weeks from April 1st and to up to April 14th. And we keep the social distancing continue for 1.5 months. So we just opened the country a couple weeks ago. So this is the case of the COVID-19 case in Vietnam. We see the first case in February, and after that we see the spike of the cases and going up to in March. And it's a little bit going down in April because of very strong action from government. And later on, we have the new case, but actually this case come from that is Vietnamese people travel back to the country and they already infected. So we easy to isolate those cases and easy to control. So in total, we have 328 cases, and if we see with the very high number of recovery, almost 300 now, and no death, very lucky for us that no people die because of this. And we have only one case in now in Ho Chi Minh City, very severe case. Actually, it's not Vietnamese, but he's UK pilot. And we now still on the in ICU, and he recover quite well. I expect that maybe next week he can be disconnect from ventilators or something like that. And that very success case, I can tell. If we compare to the situation everywhere in the world, we see that Vietnam very lucky, and at this moment we have a very successful treatment for the patient. And this the way we look at the different phase in which we had the first phase during the January and February, and as I mentioned earlier about the case travel from China. And the second phase, we see the virus spread globally, and at that time many countries put on the quarantine, and we similar to many countries in the ASEAN, we do the same thing, and we have a very good control at the airport and the border. The phase 3, in which we consider it the community level of spreading of the virus, and we have many clusters appears in very high density areas such as in Hanoi and Ho Chi Minh City and several big cities in Vietnam. And phase 4, in which the number of cases are decreasing, and it's very good for to see that how our action working during that time. This is the case. You can see that and how the number going up in March and going down in April, and now we have very few cases left. And for the symptom, it's similar like a Mary report. As a symptom, most of the cases at almost 37% without symptom. And with the symptom is more relating to fever, dry cough, and sore throat. That is very similar to many report. And my hospital, that is back my hospital, is become the center for COVID-19. And we have cluster, one of the biggest cluster actually in Vietnam. So the people from canteen and restaurant company suffer from the COVID-19, and we do not know where it come from. Actually, we don't know where the F0 cases, and we don't know how that those people infected. So that's that time. We have very big discussion, and actually the government decided to very strongly control this cluster by lock down our hospital. So this is a picture, several pictures in which our hospital, one of the biggest hospital in Vietnam, being locked down. And this is show that how strong the government want to control the endemic by lock down the biggest hospital. And the next the picture is my new director hospital, and we at that time we have the military in the hospital, and they build the few hospital inside. But luckily we don't use this few hospital at any time. And because we are very big hospital, so when they lock down the hospital, we need to send many patients back to their hometown. So those patients being quarantined at their local and they also being monitored very closely for 14 days. And during that time, we have around 900 patients, and 800 healthcare workers stay in the hospital to take care of the patient. And we close all activities in the hospital. However, because we have a leading hospital in Vietnam for many high technology and high care, so they have to accept, we have to still accept some very severe cases like acute stroke, MRI, or severe bleeding. Only that kind of patient can be admitted to my hospital. So that I just want to show one case. This is a female, 30 years old, a third pregnancy, and she went to local hospital because of bleeding. And after after 2 hours after admission, that she started to loss of consciousness and low blood pressure, and they have to send to the patient to our hospital. At that time, we have to go to the entrance of the main entrance hospital to pick up the patient. And you can see here we do during the transport to my department, they had the patient develop the cardiac arrest, and we have to do chest compression on the way during the very rainy days, and we continue CPR in the department for 2 hours. And very lucky for the patient survived. And this is a very good example of how important the healthcare system in Vietnam can do during the very difficult period of time. That really get a very good attention from the community and a lot of praise from people in Vietnam. And that's why our hospitals after lockdown, when we open, again. So we still have a lot of patients coming. So prepare for the opening of the hospital after the lockdown. We have to build or renovate many rooms for isolation, and this is one of those isolation. And the first time we have the isolation room, it's a negative pressure room. It's the first time in Vietnam we have that kind of thing in ED. For EMS response for COVID-19, most of the case, most of the ambulance transfer for the COVID patient to treating hospital is in outside of Hanoi. So the situation is very bad. We lack of the PPE, lack of ventilation, no negative pressure ambulance can show that from Korea or Taiwan, we have very casual ambulance. And this is the result of their transfer from February to May. Total response call of 1,000. COVID-19 suspected case of 1,700, in which they transfer the case with F1 or F2, and only 45 cases is positive. And very lucky for us, with no healthcare worker infected during that period. Thank you very much for your attention.
Thank you very much, Dr. Son. Okay. Right, so next we will have Professor Marcus Ong to present on how we can use data in our response to COVID-19. He's also the Director of the Health Services and Systems Research, amongst the many other hats he wears. Professor Ong, over to you, please.
Thanks, Gaia. So glad to see all of our friends here together, and that we can actually share this time of learning and catching up. So I'm just going to share a more data-driven kind of approach to our response to COVID-19, emphasizing more on the science and how we use data in our response. So similar to our experience from our friends, we had, as you know, Singapore is one of the most densely populated countries in the world, and we have very direct air connections with China and with Wuhan as well. We were one of the earliest actually outside of China to report COVID-19 cases. And I think the challenge that we are all facing is that we are actually dealing with a very sneaky enemy. If you look at the science that is coming out, we now recognize today that there are 30% of patients that are actually asymptomatic carriers or transmitting the disease. So the early cases that we had in Singapore, one of the eye-opening stories was there was a cluster involving a church. And so just the act of sitting in the same chair that the person who came, who had positive infection for the service before, resulted in the person picking up the disease, and there was no direct contact except that they shared the same chair. The other 55% will have mild symptoms, and then remember that they are actually infectious during the pre-symptomatic period as well as during their symptoms, whereas the 10% will get severe symptoms and only 5% will require ICU. So what you are seeing now in terms of the numbers that are being reported in the news or let's say on websites, I think are only the tip of the iceberg. It actually is more a reflection of community testing and contact tracing rather than the actual burden of COVID-19 in the population. So you have to keep that in mind when looking at the news and digesting some of this. I think the more important statistic for most of us is actually the mortality. And in this aspect, that is where I think there's great concern. And so all our efforts are actually directed at reducing the burden on the healthcare system, as well as the morbidity and mortality on our patients and our population, and even on our healthcare workers. So this is
on Play, if you don't mind. It's
sorry?
not on Play, your slides.
Not on Play.
Yep.
Are you able to see?
We see all the slides, the small, but we don't see the it's not on slideshow mode.
Okay, it's a lag issue. So what I'll do is, let me try and do this. Sorry for the technical issue.
Or do you want us to play for you?
How is that? Is it on play mode now?
Try pressing the slideshow mode again.
I just did actually.
Oh, no, it's not yet.
It's not. Okay, no worries. Then what we'll do is we'll do it this way. Can you see now?
Yes, we can. Or the other
Okay.
option, you want us to share the slide for you from our side?
I think this is fine. We will just move. We will move according to this.
Okay.
Okay. So as I was saying, this is the timeline of how it has actually progressed. And I think the easier way to visualize this is that we've had 3 waves of infections that have come through in Singapore. The first were actually imported cases. Most of these were actually tourists that were coming from China. And this resulted in some local community spread, initially among the tour guides, taxi drivers, and those in the service industry. And then you can see that orange is the second wave that actually came about. And now we are in the midst of a third wave, which actually is among the foreign worker dormitories. And this is where the majority of the cases are occurring now in our country. And this is a big challenge for us because some of you might know that we have a very large foreign worker or guest worker population in Singapore, up to 1 million. And that, those, for example, that are living in what we call purpose-built dormitories are about 200,000 of them. And these are very densely populated kind of military-style barracks with maybe 10 men sharing a room that they share, for example, food and utensils and common toilets. And there's another...
Sorry, may I just... I think there are quite a lot of comments about using the slideshow and full screen, because I think people who are viewing from the phones may not be able to see also.
Okay. So I'll stop sharing.
This, okay, if you slide share, you can't play slide. Okay, we'll do it from our side. I think SDGHI is playing the slides. Okay.
Okay.
Is that better for everyone else? Sorry, Prof.
No worries.
Yeah.
Okay, I'll just say next slide.
Okay, Gaia. We can see now.
Okay,
great.
thank you. Thank you.
Okay, just back to the previous slide, please. Yes, so I was referring to the dormitories situation. So we've actually had to mobilize whole of government response to actually deal with this outbreak in very close quarters. So including mobilizing hospital teams to go into the dormitories in what we call basically search and swab kind of operations, where we are screening thousands and thousands of workers and then sorting them out, those who are not infected, moving them out into facilities like hotels, military barracks, and then those that are positive, moving them into community isolation facilities. So some of you might have visited, for example, Singapore Expo. We've converted that to actually house several thousand isolation patients who are relatively well. We have mobilized cruise ships, for example, to put people who are in isolation, schools, or even exhibition halls. Next slide. And I think the numbers are actually quite informative. So we have currently more than 30,000 cases, of which maybe about 18,000 are active. But I want to highlight that those that are hospitalized at the moment have actually dropped to less than 1,000. Whereas the patients that are still in isolation in community facilities are 16,000. And to this date, basically our mortality is still very, very low. There are actually now 24 patients that have died, all of them above the age of, I think 55 is the youngest. And so by and large, we have managed to actually protect the healthcare system in that we still have plenty of ICU beds available, plenty of hospital beds that are available. Most of the patients are fairly well. They are cared for in the community and that they are actually being taken care of with minimal kind of healthcare needs. Next slide. Okay, so a little bit about the EMS response, and you can see our typical PPE posture. So unlike some of the, you can see the EMS response in some of our colleagues in the other countries, you can see that our PPE response is actually quite measured. So our standard is actually the N95 mask, goggles, and the disposable gown. But we don't wear the Tyvek, bunny suit that you saw in Taiwan or Korea. And that's because our philosophy is actually that, with each case, we would actually discard the gown if there's a suspect case that is transported. The other interesting finding that came out early in our experience was that we had one case in one of our community hospitals where the patient was handled all the way from EMS to emergency department to the ICU, and the patient was intubated with a pneumonia. And only after the patient was in ICU, the test actually came back that it was COVID positive. So along the way, there were actually more than 40 plus 50 healthcare workers that had been exposed to aerosolized generating procedures, but they were only wearing the normal surgical mask and with hand rubbing kind of hand hygiene. But there was zero actually healthcare worker infections from the episode. So it is our belief that actually good surgical mask and hand hygiene actually is fairly protective. Next slide. Okay, in terms of the impact on the EMS service, we have actually seen a decrease about 10 to 20% of our call volume, similar to what our colleagues in the other countries have shown. But this has started to rebound, and you can see that the numbers are climbing back to baseline. And in fact, we are expecting now with our opening of the community kind of lockdown that the numbers will continue to increase. Next slide. And the pattern is that there was actually a decrease in the priority 2 kind of cases, but the priority 1 was more or less stable. And you can see priority 3 actually is slightly coming up. Next slide. And what was, of course, very obvious is that the COVID-19 conveyances were increasing and driving this. And interestingly for us, some of that call volume is actually coming from the foreign worker dormitories where they need transfer back to the hospitals. Next slide. Okay, we also asked the question, how is COVID-19 affecting out-of-hospital cardiac arrest management? What I think is interesting for us is that we did not see the increase or the spike in the number of OHCA cases, unlike what was reported in Italy, where basically is related to increased thrombosis or coronary kind of events. For us, I think the community infection rates are still very, very low, and so we have not seen that effect. The other concern was, is it affecting bystander CPR? And you can see that by and large, our bystander CPR rates still remain fairly high, as well as reinforced by dispatcher-assisted CPR. So this is very encouraging for us to know that the public is still willing to respond, and they are actually following dispatcher instructions and even bringing AEDs to the scene. Next slide. Okay, how about the impact on the emergency department? Similar to EMS, we've actually seen a decrease in the ED attendances, so about 10 to 20% over that period. And if you look at the bottom left, that is mainly driven by a decrease in the P1 and the P3 cases. The P2 remain more or less similar. So P1 is the highest severity level. And of course, there's an increase in the fever type of cases. Next slide. And if you break it down, actually what is driving the decrease is actually a reduction in the number of chest pain and fluid overload patients that are coming to the emergency department. And interestingly, the STEMIs actually remain the same. So my theory is that basically there's a self-triage going on in the community, that patients with chest pain that normally would have been anxious will come to the ED for a workup, now staying away. But those with a STEMIs and all that are still coming. Next slide. And similar for ED admissions. So we have seen a drop in inpatient admissions, very similar pattern for the P1, P2, P3, and of course, increase in fever. Next slide. And when you break it down in terms of the diagnosis, we have seen a shift from chest pains, and of course, traumas have also decreased because there are less cars on the road, the construction sites are not in operation, but rather there's increase in pneumonia and fever type cases. Next slide. Okay, so just a little bit more about the science. So I think what is coming out is that we know that we are now dealing with a three-phase kind of disease. So COVID-19 can be thought of as a disease that occurs in 3 weeks. The first week is when the patient is pre-symptomatic and starts to actually have symptoms. And this is when you can actually pick up early those that may have an increased requirement for oxygen or increased requirement for higher level care. Week 2 is where they will have the highest incidence of complications, the peak of oxygen need and ICU care. And then there's a recovery phase in the third week onwards, where then, patients either have progressed, got worse, or they are recovering, majority of them. Next slide. The other thing that we now know from the local Singapore data is that the mortality and morbidity outcomes are very closely linked to the age and the pre-morbid conditions. So you can see here that we've broken down by age groups. The group that is less than 35 actually have minimal kind of complications. So blue is the need for oxygen, and orange is the requirement for ICU. However, once you go to the age above 65, for example, then you are talking about 30% that require oxygen and maybe up to 20% that require ICU level kind of treatment. So it is very much age driven. Next slide. The other thing that we have now got the science to back up policy is how long should we keep the patient in isolation before they are safe to be discharged. So what you are seeing here are actually the cycle threshold value. So this means that when you're running the PCR, how many cycles do you need before you have to amplify the virus to a detectable level? And the good news is that after 14 days, about 2 weeks, the cycle threshold becomes above 30. In other words, you may have a positive PCR test. However, next slide, if you look at it, if you correlate the cycle threshold with whether you can actually culture viable virus from the patients, you can see that above 30, threshold of 30, basically there's hardly any viable virus. In other words, although the patient is testing positive, what you're testing positive for are actually fragments of the RNA from the virus rather than a live virus. So based on this, Singapore has actually adopted new guidelines that patients can be safely discharged after 21 days of isolation with a further 1 week observation in the community. Next slide. Okay, finally, just to share a little bit of my own research, which is building conceptual models and simulation models to advise health policy. Next slide. So what we have done is actually use basically a systems dynamics type of simulation engine, and we are building both pandemic as well as resource models for the hospital system and Ministry of Health. Next slide. And so for those of you who are interested in how the architecture is and how we use data to feed into this simulation modeling, welcome to contact me. Next slide. And we are actually using this to answer questions using a scenario-based approach on how much bed capacity do we need, how much isolation capacity, how many ICU beds, and how do we prepare for the return to business as usual. Next slide. Okay, and so this you can see some of the models that we've produced that are helping to advise capacity and policy, both at the hospital level and national level. Next slide. Okay, and then some scenario testing with 95% CI. Next slide. One of the interesting questions that I'll close off with is what had happened if we had not had aggressive contact tracing in Singapore? And you can see that the model shows that the numbers would have been tenfold in terms of the numbers infected and those with complications. And so one of the features that we have been able to show is that our contact tracing rate is about 80-90%. In other words, for every case, every 100 cases that we find, about 80-90% we can actually trace the kind of chain of transmission, and we can effectively isolate them. The remaining then, of course, are the asymptomatic cases, which are quite challenging. Next slide. And similar to Korea and what you've seen, for example, in China also, we have safe entry kind of apps and contact tracing kind of apps that now have a penetration more than 1 million of the population. Next slide. Okay, what's going to happen in the near future? So there are 3 scenarios that are models show. The first scenario is on the left, which is a single kind of wave that peters out over 6 to 9 months. I think this is probably the least likely scenario now. The second scenario on the top right is more likely, where we have repeated waves of infection, but because there's experience learned about the community management as well as basically some mitigation factors, you see that the waves will decrease over time, and maybe over a period of 12 to 18 months will slowly, hopefully, die out. But the last scenario is also possible, where epidemic becomes endemic. So in other words, you never can fully get rid of COVID-19, but it will remain endemic within the population and can actually come up with clusters. So what is unknown is how long it will take to develop a vaccine or some effective drug treatment. Next slide. So this is my last slide, which just recaps some lessons that we have learned in reflection. So I think COVID-19 is a test of three things: the healthcare system, the government response, and social capital, meaning whether the population is willing and prepared to work with the government and the health authorities. And that preparedness matters, whether in terms of pandemic plans, legislation, mobilization of resources, or providing effective PPE and enough supply for your frontline staff. It requires a whole of government, whole of society response. And we have been fortunate in that we have actually very few healthcare workers infected, and most of those we trace to actually be from a social setting rather than from work. And it's key to protect the healthcare system to reduce mortality and morbidity. And data is one of the key things to improve our response. So my friends, this will not be quick. It's not going to be pretty, but we will need a paradigm shift in our thinking, and the world has changed, and we need to tackle this together. So thank you very much.
Thank you very much, Prof. Ong. Okay, we would really love to hear a lot more from each of the speakers because there's so much to share. But unfortunately, we are really short of time. So we've come to the end of our presentations. Now for the very exciting Q&A and panel discussion part, I will hand over to Faith from Philippines and Shengwen from Taiwan to lead this part of the discussion. Over to you, Faith and Shengwen.
Thank you, Gayathri. And thank you so much to our speakers who have shared very insightful and comprehensive presentations from their experiences in their countries. We are now joined in this Q&A session by a set of panelists from members of the AAEMS regional chapters also to help us be enlightened on our questions on EMS. And I'd like to introduce them. From Japan, the past president of AAEMS and professor and dean of Kokushikan University, Professor Hideharu Tanaka. From India, director of JVK, Emergency Management and Research Institute, Dr. Ramana Rao. From Singapore, Home Team Chief Medical Officer and Consultant at Emergency Department of Tan Tock Seng Hospital, Dr. Nang Yi Yang. From Malaysia, Emergency Physician from Hospital Sungai Buloh, Dr. Sarah Karim. And from Indonesia, Senior Lecturer and Consultant at Universitas Brajamulia and Zafu Anwar General Hospital, Dr. Ali Haedar. And from Thailand, Emergency Physician and Director of Siriaja Hospital Mahidol University, Dr. Sattha Riyapan. Shengwen, would you like to start our Q&A session?
Yes, thank you, Faith. We did have some questions from our participants before the webinar, and we would like our speakers to address some of them right now. In the interest of time, we ask to keep your answers brief. The first three questions goes to Dr. Ramana Rao, and I also typed them into the chat box for you to have a better understanding. So the first question is, how can we as pre-hospital care personnel lessen the impact of COVID-19 on vulnerable populations, such as children or women, cultural communities, or elderly? And the second question is, how did the COVID-19 pandemic change the dispatch and call protocols in your EMS system? And the last question is, when in the EMS process, from call taking to disposition will be the best time to screen for COVID-19 patients, and how?
Thank you, everyone, and then nice to see all the colleagues here in this webinar. the pre-hospital care personnel, how we can impact this is, I just wanted to show you how the government of India, because of 1.3 billion population, how it has responded is, initially on 22nd March, the government of India has tried a social experiment where we have been exposed to a one-day curfew so that everything is put into a standstill, what we call lockdown. And secondly, we have banned the international travel and then closed all the borders from the neighborhood countries. And thirdly, we have tried to gather the community's participation by lighting lamps and for about 9 minutes at 9 p.m. And finally, the regional cooperation in the Southeast Asian region and being actively involved with the G10 also. I want to tell the entire group here about a very important thing what India has adopted by developing an app where people are encouraged to download that. Now about 127 million people in India are using this, and it is very useful for the elderly people because it gives us the status of where they are at a lower risk or higher risk. If they have any ILI or influenza-like symptoms, the information will be received by the district surveillance officer and they proactively come and then take care of it. So India has witnessed 2 phases, and currently now the lockdown period is over. Particularly for the children, they are not being put into the schools again, and they are being not allowed on to any of the movements. So they are mostly confined to the homes. Elderly people with diabetes and hypertension, their categorization to lower and higher risk is being happening. Now from government of India, the entire epidemic is being managed by the state for some time, and now at the district level and in the containment areas in a small pockets. As far as the EMS protocols are concerned, we have been given a triage questionnaire by government of India, which is being adopted. And that is one level where the screening is being done in all our emergency response centers. You know that we run a public-private partnership mode. The second is when our paramedics or EMTs go there, and if there is a change, and they would also be able to really bring some criteria, and then they will take the advice of the doctors who are available in our centers. The third component is now there's a district surveillance officer. We have a program called Integrated Disease Surveillance. And with these 3 systems, screening is done, and low risk, high risk. And we have 3 levels of institutions. One is COVID care center, something like a hostels or a hotels. We have a COVID health centers where district hospital 10 exclusive beds are made for the mild and moderate cases. And in every state, 1 or 2 hospitals exclusively for COVID where the intensive ICU care beds are being taken. So for the response of all the 3 questions, what I just wanted to tell you is that the government of India, the state government and the district level government, now it is being really the social mobilization has happened. People are encouraged and then being empowered, and they are using the technology. The EMS system is also involved not only in provision of pre-hospital care, but we are also involved in testing at the community level, as well as we are also a part of the frontline containment team in the red zones, what we call. We work along with the municipal staff. We also work along with the health staff and the revenue department and the police also. This is what, so far 250,000 COVID related transports have been made, and we have out of the 13,600 ambulances, 4,000 ambulances are fully converted as dedicated COVID ambulances, where we are able to optimize the use of PPE. And in the country, the use of PPE by the healthcare providers and the EMS personnel are put into 3 levels. One for the driver of the ambulances, another for the EMT or the paramedic, and one for the healthcare providers who are working in the intensive care units. We are also encouraging our paramedics to reduce the contact with the patient, and then we are encouraging them to sit along with the driver rather than the patient compartment. And we have made necessary protocol changes in the pre-hospital care, either on oxygen delivery or some aerosol procedures which are being minimized. So this is what I just wanted to share our experiences in the limited time possible. Thank you.
Thank you, Dr. Rao. And for the next question, it goes to Dr. YY Young. And YY, so the question is, what changes need to happen for EMS to effectively respond to a pandemic?
Thank you for the question. Yeah, so in terms of the things that EMS has to do to effectively respond, I'll put it into a few main areas. One is protection for EMS staff in terms of having adequate personal protective equipment. Because if your staff are not protected and they all start to fall sick or they don't feel safe to work, then you have a problem, a morale issue, and also if you're contact tracing, right, then a lot of people will end up, getting quarantined. If you're not contact tracing, then that presents its own problem where people start to fall sick, as seen in some places as well. So mask fitting for the EMS staff is also important. Training for infection control, and even having proper procedures to put on and take off all their PPEs. And all these things with modifying your procedures to protect your staff, right? Cohorting, monitoring of your temperature, that's important. The second one, I would say ambulance and equipment. So the ability to have a procedure to disinfect the ambulance after every transport, and also other ways to protect your ambulances, either lining the equipment, wrapping the equipment, or having some way of doing disinfection. We use this thing called a SteriMist, which basically aerosolizes hydrogen peroxide. That also helps us to disinfect the ambulance in about 15 minutes, and you can put it back on the run. Airflow management, I think this is also mentioned. I think someone also mentioned about negative pressure ambulances. That I think is a luxury, and it's really expensive to maintain negative pressure in a moving vehicle. Even negative pressure in a hospital is extremely expensive because the rubber, the silicone, the gaskets all go. Yeah, next one is EMS clinical processes. So there's a lot of modification. Your dispatch center needs to be retrained. They need to ask questions specific to COVID-19, ARIs, fever, and also other clinical process include like PPE requirements for the patients, for the staff, and having criteria for identifying potential cases. All this is very important because if you don't have a clear criteria, it's a problem. And lastly, when you're doing aerosolizing procedures, right, there needs to be modifications and training for that. Okay, so I have a couple more categories: data flow and collection. So there's a big problem because EMS tends to work across, may not be in the same community as the hospital staff. So if your EMS is pre-hospital and a different agency, data may not flow from dispatch from E to EMS back to ED and the hospital. And even from the hospital, when you realize it's COVID positive, it needs to give the information back to EMS so that they are aware, they can track whether the staff need to be monitored as well. So all this movement tracking, knowing who is dealing with which patient is important for contact tracing in the future as well. So all this data fusion is very, very key. Training for providers, education to understand the disease so they know how to act accordingly and adapt their behavior. And lastly is communication across the workforce, because what we're seeing is that very rapid changes in case definitions, in procedures, and it's hard for everybody to keep up. So the last things is contingency planning. I won't say too much about it, but I'm sure everyone is doing it already. And support your EMS staff, morale, mental health, engagement with staff, leadership, and also helping staff through personal challenges. So staff may have young kids, elderly family members that need to be taken care of. If all these things are not taken care of, they may not be able to work effectively. And and the last part about support for EMS workforce is culture change, which is a key issue because it's not easy to take on new behaviors, practice in a new way, and things that you're not used to. So these are my top of my list. Thanks.
Thank you, Dr. Y. Thank you for sharing. I personally think that the communications across the whole organization is quite difficult.
Yep.
Okay, then we have two questions goes to Dr. Professor Tanaka.
Yep.
And yeah, so the first question is, how has COVID-19 pandemic affected the training of EMS personnel? And how does AAEMS propose for EMS agency to address this?
Okay, let me have share my slide. And okay, okay, so as you know, the number of the new patients in Tokyo is almost peak in middle of the April. Now it's a decrease, but still number of the here and early June increasing again. So that's mean to say that if we allow to the move anywhere in the people, that make more difficulty. So how is the COVID-19 pandemic attack to the training of the EMS personnel? So this is for schema from Japan, and we have a 44 private school and then 10 government EMS school. So totally 3,000 and every year we will produce. However, that's most of the all the school cannot continue to do that. Now we do web-based education for didactic, but as you know that we cannot do simulation scenario or hospital training. So those part is 1/3 of the total length of the training. So probably simulation scenario can be do next month or few months. But in the hospital training, most of the hospital cannot accept taking the hospital training. So this is our paramedic law and provide at least 400-hour scenario and the hospital training should be done. And our answer is we discuss with the government and then also discuss with all the paramedic education society. So then decrease 400 to 200 and accept the only this year. And we did hospital training, but probably that's 50% of the total length. And instead of that, we give them the simulation scenario, web-based or VR. So VR, virtual reality technology is one of our new equipment, and probably we developed some of the scenario on for the training. So actually, that is an impact for training EMS personnel, EMS school, and also in the EMS personnel itself, they cannot do any kind of the hands-on skill training, trauma or cardiac arrest, everything is now quit until end of the August. So after end of August, and we will recertificate. So probably that the continuing education is now all the agency of the continuing education suspended for at least half years. That is actually that's a pandemic attack to our training EMS personnel. And other is competency, and I would say that it's very difficult to say that during our situation, and probably teamwork, EMS personnel protection skill, and that is very important. Also, some of the history taking for more detail for COVID, family history, or more people should talk about the kind of the COVID personal history. Probably that it takes longer than before. And the mind is a support for citizen. So I would say that I cannot say that the good answer to competency right now, but And I think that's the way that they work well and same as before. Thank you so much.
Thank you, Professor Tanaka. And we will have two questions goes to Dr. Sarah. So the first one is that Dr. Sarah, would you please kindly share your practice in disinfection of ambulance in between consecutive runs of COVID-19 patients?
Okay. Oh, I'm not showing my face, right? Okay. Okay. So when you are talking about disinfection, now there are a few things you need to remember. Time is limiting factor in your disinfection. And usual time is between 30 to 60, depending on what you do and what you use. The second one, space is the second one would be time is also dependent on what type of things that you use, whether you use UV light, whether you use spray, whether you use mist, or whether you just wipe. And the third thing, space is also a limiting factor. When you have multiple ambulance runs, multiple patients being sent using many ambulances, the space for decontamination is now an issue. So how do we do it? Well, you need to have few things. Combination of fleet flexibility and understanding the clinical context of your patient and method of disinfection that you are using. So I have a few simple rules that I use. The first one, don't limit your transportation only to ambulance. In managing COVID, use vans, use buses. The only thing that I have not used is trucks. The second thing is separate between your EMS and COVID transport. So COVID transport has two types, a specialized transport and the routine COVID patient transport. So this routine transport, you can wait. So take your time, don't rush on your disinfection. The third one, if you manage your rule number 1 and number 2 correctly, then you can proceed disinfection happily without being rushed. And in my center, we use the spray and wipe and the mist method. The mist method we use for bigger vehicles, the spray and wipe we use for our usual ambulances. So thank you for the first question.
We do have second questions for you. That is, how did you balance EMS use for the COVID-19 patients and non-COVID-19 patients, given the rise in the suspected cases?
So a little bit background. I'm working in the COVID hospital for Malaysia. And our population right now around our area cannot come to our hospital unless they are COVID patients. So it is a bit challenging for EMS to balance the two. Now, the key to balancing between the EMS used for COVID-19 and non-COVID-19, you have a few things you need to monitor. The first, you must understand your area. Which are the areas that is now going to be affected by the change in your hospital status? Whether your hospital right now is going to be dedicated to receive only COVID patients like our hospital, or whether your hospital right now is open to receive both. The second one, you have to monitor the type of cases that you are seeing with the now statistic. That means you cannot look at historical background because historical background does not have movement control order, lockdown procedures and all. That is not going to be a data previously that's going to help you. You need to monitor your data now and then. The third thing is you need to broaden the perspective of what is sentinel event during COVID. What would be the sentinel event that you want to monitor? This event will lead me to put in more vehicles for this kind of response. So the sentinel events that I usually look at is the type of death that has happened. So we have to discuss right and then to find out whether this is because our fleet missed or because there is a limited access to healthcare. And the third one is when you deal with all agencies, you must understand their fears. Fear of an agency to respond is something that should not be taken lightly. So you need to address the fear. Now, when you manage the operations, you separate the two response whenever possible. So by separating the two response, by having a different team to manage COVID, having a different team to manage non-COVID is good in terms of managing risk. Today, team A is only doing COVID. If they have an exposure, it's limited to team A and only population that is related to COVID. If you have mixed around between the two, then you have problems when you have got accidental exposure to your healthcare personnel. So that will cause your fleet to have to stop for a while for quarantine, and it makes matters worse when you're managing both. So that would be my answer for 2.
Thank you for sharing. I really learned a lot from you. And my next two questions goes to Dr. Sattha. And my question is, for countries in Asia, how else should EMS service change to adapt to the new normal?
Thank you, Dr. Shengwen. So what else? I think that besides we talk more about the PPE, the cleaning, the ambulance. I think that besides this is we found our challenge is we have the room of ability to take care of our patient. So we have to balance between the risk of our provider and the benefit of our patient. So I think right now we don't have the perfect protocol to take care of all of that thing. So it should be need to balance of that. So the one thing it should be raised up is the critical thinking of our provider. Sometimes even we try to tell them to avoid aerosol tracing procedure, but sometimes we found that we have the low risk of COVID-19 patient, but the patient need to have a AGP, aerosol tracing procedure. So I think sometimes they should thinking of that. Some patient might need some AGP and in outside of hospital, or I think it's ability to use more the online medical direction, such as the telemedicine. And luckily, in our center, we got the community support from our tele company. So they give us free the set of the body worn camera, the telecommunication system to see the patient at the scene and help our provider to decide. I think just yesterday we have the severe asthmatic asthma patient with a collapse. So if they don't do any the back wall mask, or they don't put the advanced airway, that patient gonna die. So it has to be decided about that. So and what another thing else that I think it should be changed for the EMS service is that the Dr. Tanaka said before about the support community also. I think there's one thing that we have experienced is our EMS service is very close by to the community. So right now, we found that our community have a lot of problems. They lost their job. They have no money to get some food. So I have right now we go outreach to our community to link them with another organization to get them to get the support for their food, for their needs, and anything else. I think that this is a chance for the EMS to do that too. That is for my answer to the first question.
Okay, thank you for sharing. And my second question was about the PPE. And would you please kindly share your practice on donning and doffing in EMS practice to prevent infection among personnel?
So in my center, I think it's very similar that I heard for everyone. But I like the Dr. Wai said we should take care about the fear of our provider too. So my protocol is quite a little bit different. So after we receive the call from a dispatcher, we call the call back to the caller to ask to reconfirm the two things. Actually, the two things is the first one is the risk of COVID-19 again, and the second one is to ask again about the chance of aerosol tracing procedure to decide which type of PPE we need to go out, and we donning at the station before we go out to the field. And when we doffing, we doffing after we get back to the station. We do it at the station.
Yeah, and Face, would you please handle the questions left?
Thank you, Shengwen. We have a question here for Dr. Ali Haedar. Hi, Ali.
Hi, Dr. Faith. How are you?
So your question here is, how can EMS personnel quickly identify patients with ARDS in suspected COVID-19 patients, and what will be the appropriate airway management?
Okay. Thank you very much for the question. So actually, the management of acute respiratory distress syndrome in the pre-hospital setting is not an exact science, but unfortunately that the good patient outcomes rely on the EMS personnel ability to assess the ventilation, oxygenation, work of breathing, lung function, airway resistance, and also the airflow. Yet, complaints of the dyspnea account for a significant number of EMS responses. So the attempts to stratify the significance of the respiratory distress by emergency medical dispatch protocols have been largely unsuccessful, leaving most EMD protocols to triage patients with breathing problems into a high priority response. So this includes like a difficulty of speaking between breath and the presence of cyanosis, diaphoresis, each of which are objectives and significant assessment findings. So although any dispatch for difficulty breathing could be serious, the presence of these objective findings certainly raise the index of suspicious of ARDS. So I would suggest 3 signs that suggest imminent respiratory arrest in a patient with acute respiratory distress: decreased level of consciousness, inability to maintain respi, effort, and cyanosis. So the presence of one of more of these warrants immediate intervention, because untreated respiratory arrest will lead to cardiac arrest in a very short order. So immediately life-threatening conditions associated with complaints of dyspnea include SARS from COVID-19, of which will be treated during initial assessment. So we need to have strategies like prioritizing oxygenation and ventilation with lower aerosolization risk. So all rescuers should don PPE even before entering the scene, and also limit the personnel to only those essential for patient care. And also not to forget clearly communicating the COVID-19 status to any new providers before arrival on scene or receipt of patient when transferring. And another one is the strategies for prioritizing oxygenation and ventilation with lower aerosolization risk. So for particular oxygen therapy with a low flow device, we should not be worried as they are non-aerosol generating medical procedures. But if breathing is inadequate, the ventilation must be provided without delay. As ventilation can be non-invasive, we understand that CPAP, I think it's the most often used pre-hospital non-invasive ventilation device, aside from BVM and CPAP, is appropriate for nearly or all patients who have a pattern airway with inadequate breathing or invasive ventilation, and both are aerosol generating medical procedures. So it is very important to attach the HEPA filter securely to any manual or mechanical ventilation device in the path of the exhaled gas before administering of any breath. And the use of these devices with the HEPA filter should be done with a tight seal. And if the patient falls into respi arrest, of course, we need to perform intubation with minimize the likelihood of failed intubation attempts by assigning the provider an approach with the best chance of first pass success to intubate. And also by video laryngoscopy may reduce intubator exposure to aerosolized particles, and this should be considered. So now the thing is, if the intubation is delayed, they need to consider manual ventilation with a supraglottic airway or back mask device with the HEPA filter. So that's my perspective. Thank you, Dr. Faith.
Thank you, Dr. Ali. I think you have covered most of the things that you would propose for the pre-hospital care. But another question here would be, how do you safely conduct CPR in arrested patients in out-of-hospital cardiac arrest?
Okay. Thank you again, Dr. Faith. Yes, we indeed need OCA guidelines during the COVID-19 based on situation and settings specific consideration. So the first one is for the lay rescuer. The rescuers in the community, of course, are unlikely to have access to adequate PPE and are at increased risk of exposure to COVID-19 during their CPR. However, when the cardiac arrest occurs at home, the lay rescuers are actually likely to already have been exposed to COVID-19. The lay rescuer performing the chest compression, they need to perform at least hands-only CPR after recognition of a cardiac arrest event, and to use the face mask or cloth covering the mouth and also the nose of both the rescuer and also the victim, that it may reduce the risk transmission to the bystanders. And also it is safe actually for lay rescuer to perform shock with the AED to assess and treat the victim of OCA. And especially for the healthcare workers, give the best possible care with two very important considerations, which are PPE and aerosol generating procedures. But of course, without delaying the CPR to avoid the fatalities. So it requires adaptation to our EMS protocol. In order to mitigate the risk of transmission to EMS responder, the EMS personnel should use PPE for aerosol generating procedures during their resuscitation, and also to consider defibrillation before donning a PPE for aerosol generating procedures. And during transportation, the OCA patient, it is considered for the family members and other contacts of patient with suspected or confirmed COVID-19 should not ride the transport vehicle or ambulance to avoid the virus transmission to them in the limited space in the ambulance. Also, if the return of spontaneous circulation has not been achieved after appropriate resuscitation efforts in the field, consider not transferring to the hospital. That's my perspective. Thank you so much, Dr. Faye.
Thank you, Dr. Ali. There are still some questions here for our speakers. Dr. Matthew Ma, there's a question on, should we devote resources for innovations in EMS, and what do you think should be our priorities? Dr. Ma?
Opening up my mic. I think there's old saying that necessities are the mother of invention. I think during the pandemic responses everywhere in the world, we have witnessed many innovation solutions that are pivotal in helping us. I think there's need to be a balance between protecting the EMS personnel and providing optimal patient care. So I will put my priority on three areas of innovations, technology, that kind of things. First, I will propose a contactless and remote sensing and monitoring device. Through this, you don't have to contact the patient, it's remote sensing. We already have technology that can help us assess and monitor our patients in rather innovative ways. So I would say this is the first, contactless and remote sensing. And second is a way to smart triage the COVID risk among patients. And this system would necessarily incorporate personal demographic, health, travel, and contact information. It will probably deploy modern contact tracing technology, big data analytics, using data from multiple sources, including the use of mobile phones, plastic monies. But again, the only concern, of course, is intrusion of personal privacy. And lastly, I think the third priority for me would be the deployment of telemedicine so that we can direct the needed help to those in emergency situation very early on.
Thank you, Dr. Ma, for your insights. In relation to technology and innovations, I'd like to direct our next question to Dr. Marcus Ong. How important in EMS services is case detection during pandemics, and how does information systems help? And related is, how do countries assess effectiveness of community quarantines as a response to pandemic, and does data help?
Yeah, thanks, Faye. So I think COVID-19 illustrates very well how important data is to our response. And I think EMS has a part to play in being able to collect, for example, surveillance data and having your routine data systems, data collection systems to be linked, for example, with hospital records or national records. And this is absolutely vital in, for example, assessing how effective your lockdown is. Because you must remember that every lockdown has a price to pay. So you may not die from COVID-19, but maybe you will die from starvation because you have no job, no food, and you can't go to work. So there is a balance that is needed. And I think data and real-time data and statistics are important to guide policymakers to make the right decision. So similarly, I think if EMS data systems are linked to public health systems, it will help a lot with contact tracing and with being able to actually, detect cases quickly and to trace all their contacts and isolate them. And finally, I want to touch on innovative testing strategies that are starting to evolve. So I think some of us have seen the drive-by kind of swab testing and telephone booth swab testing that is being used in Korea, in Malaysia, and even in Singapore. There are also interesting concepts where, for example, you pool the specimens from, let's say, for example, a household. So instead of running separate PCRs for each individual member of the household, you pool them together in one single PCR test. And if they're negative, you're negative. And if they're positive, that you need to isolate this household anyway, so it doesn't really matter. And lastly, there are some interesting science coming out regarding stool testing, for example, from the sewage. And that gives you some idea of the community prevalence of the COVID-19 virus. So these are sort of relatively novel and non-invasive ways to actually do testing and use data to guide policy decisions.
Thank you very much, Dr. Ong. Final question for Dr. Herbosa. Since we touched already about community, the impact of COVID-19 in the community, is there a role for EMS in community education during pandemic, sir?
Yes, of course, definitely. The same way we have a role when we talk about CPR and prevention of heart attacks. I think the knowledge and the skills about infection control, identification of the patients who are probable or who are suspected of COVID-19 is very important. There was a lot of phobia and stigma in the Philippines with people who have survived COVID-19, and when they returned home, they were ostracized in their own communities, still having thought of by the public. This, I think, is a big role for our EMS on the ground to actually help out in the public education of the people in giving correct and reliable information.
Thank you, sir. There's another question regarding the practice of nursing practice and EMT practice. How has this been affected by the COVID-19 pandemic?
The biggest effect is on the ban on Filipino nurses for leaving abroad. So in March 9 of this year, the government, the Department of Labor and Employment banned all nurses that were supposed to leave for contracts with other countries. So they probably either lost their jobs or their employers are still willing to wait for them. If that ban is lifted, then they can leave. So this, I think, is a big effect to many of the nurses who had long work to toil, to work, to get a contract for hospitals abroad for higher pay. Locally, it's really the fear of getting infected as well. So that actually fear was actually minimized and mitigated when the government started to procure a lot of PPEs and N95 masks, and immediately the numbers of healthcare workers getting infected went down. So with that level of confidence to be able to work, we saw our nurses providing very good care at our hospital, which was converted to a COVID hospital, the Philippine General Hospital. Thanks.
Thank you, Sir Ted. Last question for Dr. Son. If for low resource countries, where do you think the money should go in a pandemic? or maybe any of the panelists would like to answer that question. If for low-resource countries, where should the money go in terms of the pandemic?
Dr. Rao here from India.
Okay, Dr. Rao.
So for us, the money should go on three priority areas. One is the personal protection equipment of the healthcare workers. The second is on the behavioral change of the communities at large in terms of practicing the physical distancing and use of facial mask, so on and so forth. The third component is on the skill building and standard treatment procedures at the district level hospitals, because our tertiary care institutions are very good, but our secondary level institutions. So I would recommend that in a lower and middle income countries with constraints in the funds and resources, this is where we need to focus according to me. Thank you.
Thank you, Dr. Rao. I think most of the questions in the Q&A chat box has already been answered by the panelists and the speakers. So thank you again, everyone. I'd like to turn back to Gayathri for the rest of the program.
Okay, thank you, Faith. Right, so thank you all for staying beyond your time. We're actually going to end soon. Just a few housekeeping matters. Okay, so lastly, we actually have as a follow-up to this webinar, we'll be conducting a survey of pre-hospital systems within Asia to actually understand the practices within Asia itself, and hopefully aim to come up with some sort of pragmatic best practice of pre-hospital systems in Asia. So maybe Maeve, can you help me show the slide? So Maeve or Meryl, slide share. Right, so if any of the pre-hospital medical directors are interested in taking part in this survey, feel free to actually email, which will be flashed on the screen soon. Okay, right. Okay, but in the meantime, while I'm waiting for the email to be flashed onto the screen, a few more housekeeping matters. So many of y'all asked about the certificates, right? So the certificates will be mailed out to all of you after this webinar, together with the link for this webinar itself, which you can share with your colleagues. The link, of course, not the certificate. Next, we would like your feedback. So in the email, please provide your feedback. And for the Singaporean participants, we'll contact you directly via email to actually sign the attendance sheet once SMC has actually approved the accreditation. Okay, right, so this is the slide with the contact details. So for EMS medical directors within Asia who are interested to take part in this survey, please do email us at the address shown on the slide. Okay, and we will contact you with the online. Okay, thank you very much. So now I'm just going to hand over to Prof. Matthew and Prof. Tanaka to end off the whole webinar. And the other thing, sorry, one more thing is that if there are some of the questions which we will also them in the reply to you via the email. Yep, thank you very much.
All right, I think this is the end. I would like to a big thank you for Dr. Gayathri for her efforts in leading all the preparations leading to this very successful webinar. I think we owe her a very big hand. I think we all benefit from the lively and very stimulating lectures and because we're still in the middle of this pandemic. So there's not time to rest and go to work. All right. So I'll leave the platform for to Dr. Tanaka, Professor Tanaka, who is going to introduce our biannual meeting. Next year is going to be bigger and better than this year.
Thank you, Matthew. And so actually, that today is supposed to be we have to have EMS Asia Tokyo. So unfortunately, but I'm moved to 2021 September Tokyo meeting. So I would like to propose to the next meeting will be Tokyo again, and 2021 Tokyo. So I hope meet you everyone, and I think that is I would like to enjoy meeting, and also we would like to share. I would like to have a good meeting too. Thank you for opportunity to discuss this. Thank you.
Can we have a group photo?
Excuse me? Hello?
Yes.
Yeah.
Yeah, should we have a group photo together for all speakers and panelists?
Yes, we will. And Gayathri will navigate us through that.
Okay, great. Thank you all.